pediatrician in the Salt Lake area, um, and medical director for a lot of ambulatory work with the community with children's health. And really grateful to be able to welcome everyone this morning. Just as a reminder for our pediatric update webinars, cameras and microphones have been essentially muted, but we really want people to be active in the chat. So this is a hot topic today, and we would love to hear the questions that you are encountering in your offices as you're trying to navigate a pediatric practice and support public health and all of these things in the landscape we have now related to vaccines. So please be active in the chat. We really like that and encourage that. All right, just as a reminder that we're recording this and this will be posted later on the Primary Children's YouTube channel. So you can tell others that they can review this if they would like to as well. And there will be CME for this. And Kylie Townsend has been so awesome to set up these webinars for so many months and years now. We appreciate that, Kylie. She's going to drop in the chat the CME code number, and we'll make sure to mention that audibly as well for those who are just listening. You can go to the next one. Okay, this is our topic I hinted at a little bit, navigating the evolving landscape of vaccines in the US. We all know that this is a frankly unprecedented time, and so thinking through how do we navigate this? What's going on? What do we need to know? And what do we need to look for? All of those things are questions we'll be thinking about. We are very fortunate to have Tamara Sheffield here. I think many of us know Dr. Sheffield. She is medical director for immunization programs for Intermountain Health and has been a leader in our community for decades related to vaccines, and is my go-to when I have questions about vaccines. We are very, very fortunate to have her in our community. And then Dr. Andy Pavia, who's been with us on the webinar several times in the past. Again, very fortunate to have Andy, who's a national and international expert in pediatric infectious diseases, in virology, and with vaccines. And I know Andy's just getting back in country, so this is a really kind of him to be with us this morning as well. We're going to start off with Dr. Sheffield. So Tamara's going to tee us up with what's currently going on in the landscape of vaccines related to the CDC and public health. And again, keep your questions going in the chat. And Tamara, over to you.
Thank you so much. I'm just trying to get myself into a presentation mode here. Not sure if that's going to work for us. There we go. Thank you. So I have nothing to disclose. The CDC's Advisory Committee on Immunization Practices was first convened over 60 years ago in 1964 by the U.S. Surgeon General to assist in preventing and controlling communicable diseases. It recommends newly licensed vaccines to be incorporated into the routine immunization schedule and reviews prior recommendations for revision as new science becomes available. According to the Affordable Care Act, ACA vaccines recommended by the ACIP must be covered by insurance companies. This body also dictates Medicare Part D vaccine coverage with no cost sharing of ACIP recommended vaccines due to the 2023 Inflation Reduction Act. In 2010, the ACIP adopted the GRADE process for evaluating vaccine recommendations using an evidence to recommend ETR framework, which we will review. The established process for vaccine acceptance is by the medical community, and funding agencies starts with the FDA. After receipt of application for licensure accompanied by supporting clinical and immunologic trials, the FDA convenes an advisory board, the Vaccines and Related Biological Products Advisory Committee, or VRBPAC, prior to making vaccine approval and licensure decisions. Once a vaccine is FDA approved, the CDC uses the ACIP as its advisory committee to develop formal vaccine recommendations. The CDC then may clarify fine points of vaccine delivery through published clinical considerations. The director of the CDC ratifies the ACIP's recommended votes, and in the absence of a CDC director, the Secretary of Health and Human Services, who's currently Secretary Robert Kennedy, has been ratifying ACIP recommendations. In order for insurance companies to be required to recover vaccines, they must be recommended by the ACIP. The ACIP also votes for the approval of vaccines to be included in the Vaccines for Children, that VFC program, which provides government-funded vaccines for uninsured children and children covered by Medicaid through 18 years. With the appointment of Robert Kennedy Jr. as Secretary of the U.S. Department of Health and Human Services, we've seen an unprecedented changes in the process for vaccine recommendations. On May 20th, the FDA, the New England Journal of Medicine published an article by newly appointed FDA leads, Dr. Vinay Prasad and Dr. Martin Makary, outlining a new approach to COVID vaccine that shifted from support of a universal recommendation to one recommending the vaccine for persons ages 65 and older, and only for those with at least one risk factor for severe disease for persons ages 6 months or 64 years. They did reference in the article the CDC's posted list of COVID high-risk conditions, which includes pregnancy and recent pregnancy, as risk factors for severe COVID. They also stated a preference for more randomized control trials for future vaccine approvals. On May 22nd, Secretary Kennedy announced, flanked by these two FDA officials, that the COVID vaccine recommendations in the CDC's vaccine schedules would be changed without a vote of the ACIP, which had previously ratified the 2025 child and adult vaccine schedules at their October 2024 meeting. Besides recommending only at-risk persons receive the COVID vaccine through age 64 years, he also stated that the vaccine would no longer be recommended for pregnant women. In the April ACIP meeting, the CDC had presented options for the 2025-26 season COVID vaccine formula recommendations proposed by the COVID vaccine work group for a full recommendation for young children ages 6 to 23 months, for the older adults and pregnant women, and an at-risk recommendation for others. But that got a good amount of pushback from several ACIP committee members who felt such a recommendation would add complexity for practitioners and would undermine confidence in the COVID vaccine. On June 9th, Secretary Kennedy removed all 17 members of the ACIP and his executive secretary and appointed 8 new members, one who is later withdrawn. The reasons given for the overhaul of the committee was to remove conflicts of interest and bias and restore the public's confidence in vaccine recommendations. Just the opposite has happened for the medical community. In the past, ACIP member selections included a nomination process with extensive vetting by the CDC and ratification by the CDC director, and a full disclosure of any conflicts of interest. That process was bypassed in Secretary Kennedy's appointment of the new committee members. At the first ACIP meeting with the new committee, held June 25th and 26th, 3 votes were taken on thimerosal content in vaccines that were not proposed through CDC channels and had no evidence to recommend presentation to support the recommendations. The votes were proposed by new committee members, not the CDC, when these committee members are supposed to be an advisory to the CDC, not directing the votes of the committee. On June 31st, Susan Maneris, PhD, was confirmed by the U.S. Senate as the director of the CDC. She's been serving as the acting director since January. She's the first non-physician in this role in the past 70 years. Though she may find herself at odds with the current leaders at DHHS, she appears to have a strong scientific background and says CDC recommendations will be, quote, backed by publicly available gold standard science. She will be leading the agency, which now has lost approximately a third of its staff. Last week, on August 5th, Secretary Kennedy called government support. He canceled all of the government support for the further development of mRNA vaccines. These potential COVID vaccine recommendations from this COVID work group were presented at the June ACIP meeting. The evidence to recommend framework used by the CDC for its presentations to ACIP members for evaluation of vaccine recommendations includes considerations of disease burden, benefits and harms, cost effectiveness, feasibility, and values and preferences of stakeholders regarding vaccination. Discussions of equity have also been included, which, for example, helped to drive the recent earlier age for universal recommendations for pneumococcal and RSV vaccines, due to the fact that some races experience their uptick in hospitalizations and death from these infections a decade younger than other races. Another example would be including boys in the HPV vaccine recommendation because men experience an equal number of HPV-related cancers compared to women. When this framework is followed, it allows for a more evidence-based and less biased approach to recommendation decisions and provides explicit presentation to the public of the pros and cons of proposed recommendations. bypassing this process during the June 2025 meeting in the votes to remove recommendations for influenza vaccines that contain thimerosal was highly troubling as a harbinger for what the new ACIP committee might potentially recommend in the future, especially when neither the CDC nor the ACIP influenza work groups made the thimerosal presentation. Lynn Redwood, a nurse, the former president of Children's Health Defense, which is an organization considered to be vaccine skeptical, founded by Secretary Kennedy, made a presentation, and she said, quote, as a private citizen, concerning thimerosal and vaccines. And the new ACIP chair took the prerogative to call the votes. After the presentation, American College of Physicians President Dr. Jason Goldman, a liaison to ACIP, expressed serious concern over the process of the presentation and the proposed votes on thimerosal. He said many of Ms. Redwood's and the committee members' statements were opinion and made without scientific evidence, and asked if a CDC presentation containing peer-reviewed research would be offered, or would the only presentation on the topic be made, quote, by a layperson. The American Pharmacy Association liaison also asked if the CDC would provide a formal evidence to recommendation ETR presentation prior to a vote. It did not. The ACIP chair stated that in the future, the ACIP meetings will have comments by, quote, a variety of people. He stated it would be inappropriate to dismiss a presentation just because that presenter does not have an MD or PhD, that the committee wants to hear from a variety of viewpoints, and it will continue to do so in future meetings. The background of the 7 new ACIP members can be found on the committee roster published by the CDC at this website here. The group includes 4 physicians, 1 ER doc, 1 psychiatrist, 1 researcher, 2 PhD researchers who focused on risk management and safety, and a PhD nurse who's been the research director for the National Vaccine Information Center, a source of vaccine skepticism and misinformation. The most clinically relevant member of this new committee is Dr. Cody Meisner, a pediatric infectious disease specialist who's previously been an ACIP committee member and a member of the FDA's VRBPAC. Most of the new members have expressed concerns about vaccines and their safety, or have been particularly opposed to the COVID-19 vaccine. While Dr. Meisner has been supportive of vaccines, he was critical about other aspects of infection control related to the COVID-19 response. There are currently 11 work groups, which meet on a frequent cadence, a more frequent cadence than the full committee, and they bring proposed vaccine recommendations to the ACIP committee for their consideration. Work groups must be chaired by an ACIP member, and the new chairs are being appointed to existing work groups. So far, the reported plan is to retain previous work group members. The 11 current work groups include COVID-19, cytomegalovirus, HPV, influenza, meningococcal, mpox, pneumococcal, RSV vaccine for adults, RSV vaccine for pediatric maternal use, chikungunya, mpox, and the child and adult immunization schedules. The chair announced that 2 new work groups will be formed, one which will examine the childhood schedule in whole. In a concerning statement, he noted these work groups will evaluate the cumulative effects of the recommendation of those recommended vaccine schedules. They'll include interaction effects, total number of vaccines, cumulative amounts of vaccine ingredients, and relative timing of different vaccines. Another work group is to be convened to look at vaccines that have not been reviewed in over 7 years, including the universal Hep B vaccine birth dose and the MMR varicella combination vaccine. The new chair gave his own presentation about the concerns of MMRV and febrile seizures and recommended increasing the age that's recommended that children should get only the separate MMR and varicella vaccines. During the June ACIP meeting, several anticipated votes and discussions did not occur, mainly due to the restructure of the committee that happened just a couple weeks prior to the meeting. The most notable outcome for pediatric providers was that the 2025-26 recommendations for the COVID-19 vaccine were not voted on. There's a placeholder for a potential ACIP meeting in August or September that will hopefully address this once the 2025-2026 products have received FDA approval. In the meantime, the FDA has stated it's planning to remove all emergency use authorizations for the COVID-19 vaccine. So only FDA-approved and licensed products will be able to be used this coming year. Last season's Spikevax mRNA vaccine by Moderna is approved down to ages 6 months for persons with at least one underlying risk condition. But Pfizer's Comirnaty currently is only approved down to age 12 years. Pfizer anticipates that for the 2025-26 formula, it will be approved for ages 5 to 11 years, but that other formulation for those ages 4 years and younger most likely will not be approved for this coming season. Also, the HPV work group had hoped to bring a recommendation for initiation of the HPV vaccine series down to age 9 years and shifting the number of doses needed for those under age 15 to a single dose. The HPV work group did not make a presentation during the June 2026 meeting, and I think it may be a bit spooky to have presentations for changing HPV recommendations with this particular committee group. The votes which did occur include ratification of the 2025-2026 influenza vaccine recommendations, which reaffirmed its use for routine annual vaccination of all persons ages 6 months and older who do not have contraindications. Multi-dose vials of influenza vaccine containing thimerosal are no longer recommended for children, adults, or pregnant women. This really does not change our current practices, as those products have not been used at Intermountain Health in recent years. A second monoclonal antibody option for the prevention of severe RSV disease in infants was approved. Clesrovimab is recommended for infants ages less than 8 months during or entering their first RSV season. Unlike nirsevimab, the same dose is used regardless of the infant's weight, and there's no indication for administration during the second RSV season for high-risk children older than 8 months. At the June 2025 ACIP meeting, the liaison member from America's Health Insurance Plans stated that U.S. insurance plans would continue to support the coverage of evidence-based vaccines. And at the conclusion of the meeting, this statement was published. As we navigate an evolving healthcare landscape, maintaining robust immunization coverage continues to be a top priority for protecting both individual and community health. We are committed to ongoing coverage of vaccines to ensure access and affordability for this respiratory virus season. We encourage all Americans to talk to their healthcare providers about vaccines. When Select Health was asked about coverage of COVID vaccine for pregnant women after the removal of the recommendation by the CDC's adult inside of the CDC's adult vaccine schedule, that by a declaration of the Secretary of Department of Health and Human Services, it stated it would cover that vaccine for pregnant women and will continue to cover evidence-based vaccines. While commercial health plans may be one of our allies in promoting evidence-based vaccines, coverage for the uninsured and Medicaid patients has the potential to become more problematic, since inclusion of each vaccine in the Vaccines for Children federally funded vaccine program is determined by ACIP vote. The ability of pharmacists to act outside the boundaries that are determined by the ACIP is also limited by the practice acts in their various states that allow them to administer vaccines, which have been written for the most part to defer to ACIP recommendations as the structure that determines the extent of their administering rights. This could create an access problem, especially with Medicare Part D vaccines, depending on the future ACIP votes that might constrain a pharmacist's ability to provide evidence-based vaccines. Some states are looking to reform their pharmacy practice acts to move away from ACIP as the only body guiding pharmacist immunizing practices. The legislature in our geography may not be as receptive to that idea, but our pharmacy associations and public health associations will be working on solutions to this access concern. So I'd like to go ahead and turn the time over to Dr. Pavia.
Let's do a quick double check
Yeah.
here. I know, again, Andy's just getting back in country. He sent me a text last night that he would be able to join. I'm not sure. Oh, are you
I'm
on,
here.
Andy?
Yes,
Oh,
I'm
great.
right next to Tamara on my screen.
Oh,
Oh,
great.
good. Glad to hear. Oh, there you are, Andy. Okay. Thank you for being here. Couple questions before we maybe launch into Andy, your part. First, Andy, anything to add to or play off of what Tamara said? And then I have a couple questions from kind of a community pediatrician perspective.
Well, I think Tamara did an outstanding job of summarizing what's been going on. I would say she did it in a calm and contemplative manner that I think hid this degree of concern we all feel. This is really quite potentially disastrous for the health of people in the United States, particularly for children. The one other thing I'd add to that long list of things that have gone on that people may be interested in who care about international health is that the Secretary announced that he was canceling all U.S. funding to Gavi. The U.S. provides 30% of the funding to the Global Alliance Global Alliance Vaccine Initiative that provides much of the vaccine that's available in developing countries and is thought to be responsible for having saved over 30 million lives since it was put in place. And so, it's not just U.S. children who are at risk, but the effect on children around the world is going to be enormous.
Really, really key to know that as well. Thank you, Andy. We have a great question from Dr. Sarah Woolsey. Sarah, thanks for throwing a question in the chat there. She said, do you know about any other health plan statements regarding coverage of CV or COVID vaccine or other evidence-based vaccines? Is there a place to search them?
Yeah, that's one of the things we've always struggled with is whenever there's a new vaccine, wondering when people finally do cover it. And so that tends to be calls and requests to each insurance company over time. America's Health Insurance Plans is kind of the college body for or professional organization for various insurance plans. You have to be paid to be a member. And that was actually when I was a liaison to ACIP, I was a liaison for the America's Health Insurance Plans. So it has always been a vaccine supportive organization. It's right there at the table. But also talking about, making sure you have good cost effectiveness data and making sure that these vaccines make sense for a population group. This statement by them really is kind of a call to their members to back them up in supporting evidence-based practice. So no, it does not necessarily guarantee that all of the market health plans that we have will cover these vaccines. But that's one thing that we could be asking Pfizer or Moderna to do. We've done that with the past with manufacturers to say, can you canvass the health plans in the area and let us know who is covering and who is not. So that would be a good job to be talking to our partners about, but they're also pretty stressed and working hard on their own issues right now in terms of getting especially the COVID vaccine approved for the next season.
Great, thank you. Andy, anything you'd add to that related to commercial vaccine coverage?
Well, I think there's always pressure to try and have all the insurance companies march together on these things and not to undercut each other. And I think that's what we're going to see play out, is whether or not some insurance companies decide to save some money by cutting coverage of expensive vaccines, or whether there's a consolidated approach. And we'll just have to wait and see. I mean, we can sort of guess who'll take the high road and who might not among insurance companies. But Tamara, you mentioned liaisons, and the other piece of news is that the Secretary announced that the liaison organizations would no longer participate in ACIP. Maybe you want to talk about the role of liaisons a little bit, and what that means, that AAP and the ACP and Infectious Disease Society of America won't be participating at all anymore.
So that's distressing news to me. In terms of the liaison organizations, and I don't know if any of you are going to show some of those, but there were definitely statements made by them after the meeting. The AAP actually boycotted the meeting in protest of the removal of the ACIP members, and pretty much made some scathing comments about it, but also said they will be continuing to create their own child vaccine schedule. Those vaccine schedules by the American Academy of Family Practice and the AAP and others, actually, the CDC has been working really hard over the last couple of decades to come to a consensus recommendation, and all of them have been bodies that have been endorsing the CDC's ACIP vaccine schedule, so that we haven't had competing schedules out there to look at. These liaison organizations, including ACOG, the pharmacy associations, various infectious disease groups, National Foundation for Infectious Diseases, nurse practitioners. I mean, pretty much all of the stakeholders who provide vaccines have had a voice at the table, which is kind of a second round. So you have the first comments and questions made by the ACIP committee members, but then these bodies and the ex officio members are allowed to make their own statements and comments of supporting vaccines for their specific stakeholders and the people who they represent. So it's, and to ask very pointed questions as well. The AMA, I mean, for pretty much every, for our seniors, for everybody that really is taken care of by vaccine providers. So if they are not allowed to be part of this deliberation, what it does is it removes another 40 people's input of vaccine experts and advocates to down again to this group of 7 who are in their own vacuum tube and won't have the ability to get feedback or opposing ideas from other individuals. There's a public comment time for 3 minutes for each person in the public, but that has been limited. But these other groups do have the access and the ability to help make the decisions richer and more broadly applicable to their various constituents. So I think this is a devastating approach if that's what's going to happen.
Yeah. Yeah, one more impact that has is that the working groups, where much of the hard work of pulling together the science and creating the evidence, the ETRs, the evidence to recommendations, those work groups are staffed by 1 or 2 ACIP members, some CDC staffers, and then experts that are provided by the liaison organizations. For example, I was on the anthrax working group and then the influenza working group, and it's a great deal of work and a great deal of expertise that's brought to bear. So my role that Neil asked me to do is kind of to address what are we going to do about this disastrous situation? What's happening by way of responses? And of course, this is very fluid. So I will talk about a number of things that are happening that all of which are evolving. So Tamara started to mention the AAP, which, as those of us who are a little bit older remember, the AAP used to develop their own vaccine recommendations and vaccine schedules. They were close to, but not exactly aligned with ACIP. I think about 20 odd years ago or so, AAP decided that they would participate in the ACIP process and then endorse ACIP recommendations. So there would be one set of recommendations. In response to this complete restructuring of ACIP and of unilateral actions by the secretary and by Marty Makary, the commissioner of the FDA, AAP has announced that they will go back to creating evidence-based schedules and recommendations for children. Now, you may wonder, if AAP is going to do that, what is family practice going to do, and how does that overlap with obstetricians or internists? And so there's a real need to create some sort of coordinated response. That role is being led to some degree by CIDRAP. CIDRAP is the Center for Infectious Disease Research and Preparedness at the University of Minnesota. Many of you may be familiar with it. Mike Osterholm runs it. The Osterholm Report podcast is something a lot of us have listened to. And what Mike has done is to convene a group that they call the Vaccine Integrity Project, VIP. It is led by Harvey Feinberg, former president of the IOM, and Peggy Hamburg. Peggy was the FDA commissioner, among many other government posts, and has a number of other, it's a 7-member body. And they set about thinking, what are the priorities that a coordinating body can do to help prevent kind of a Tower of Babel situation where every state has its own recommendations, every professional society wrestles with it. this ersatz ACIP, of which really 6 members are have no vaccine expertise and have strong anti-vaccine histories and viewpoints. And there's a single person with appropriate expertise instead of 17 people with expertise. And so for the first couple of months, the VIP created a listening tour and talked to some 70 stakeholders. I was fortunate to be one of those, and then came out with a document. I posted the link to this in the chat, and I recommend that to everyone. Not only does it go through the timeline that Tamara went through, it adds a number of other factors, but it also talks about the risks and opportunities of coming up with a response. And so now we're entering the implementation phase, and that there are a series of recommendations that the Vaccine Integrity Project has put forward, and I'll just sort of outline them really broadly. So one is addressing vulnerabilities and establishing priorities. That will involve working with insurance companies, medical experts, and scientific groups, strengthening communication and information dissemination. I think we all realize that the information ecosystem has become poisoned with vaccine disinformation, and providing our patients and our communities with adequate and accurate information is going to be an ongoing challenge. The VIP is not going to do all of that. It is going to be coordinating and helping different organizations do that. Building coalitions, maintaining the infrastructure, maintaining the vaccine safety system, and providing assistance to state and local health departments, and safeguarding insurance coverage are other goals. But the one I want to talk about a little bit more is developing and disseminating clinical tools and guidelines. That's the one we all worry about, right? What are we going to do when the organization that we counted on to review the evidence, make careful evidence-based recommendations, no longer exists? So what many of the medical organizations have expressed an interest in doing this. ACOG and Society for Maternal and Fetal Medicine for pregnant people, AAP for children, the Infectious Disease Society of America is kind of an overarching expert body with expertise in developing guidelines, and the American College of Physicians for adults and the elderly. But how do we coordinate all of that? And so CIDRAP views itself as trying to bring that together in a way that's not been fully vetted yet. It will probably involve different groups convening experts to work on pieces of the guidelines and then assembling it into a coherent and trusted source. But again, that will help all of us in making decisions, but there are these add-on impacts for vaccine for children, potentially for insurance, and of course, vaccine availability. If the commissioner of the FDA unilaterally changes the approval over the advice of their internal experts, then the vaccine isn't available or approved for use, and that may cause limitation. So I'm happy to take questions on that. It will probably take many months. The resources that go into the ACIP, we talked a little bit about, they're enormous. There are CDC experts whose full-time job is to support ACIP. There are work group members who, when they volunteer, devote, I don't know how many hours I put into the anthrax work group, but it was a lot. And that probably wasn't nearly as busy as many of the other work groups that participate. And so reconstituting this through volunteers in the professional societies is a really big lift, and we'll have to see how that plays out. The other thing you may have read about in the news is hopefully going to prove to be one of the important things, and that is a lawsuit brought by a number of leading professional societies against Robert Kennedy specifically for unlawful unilateral changes to the vaccine system. So this lawsuit is being filed in Boston. It's led by the AAP, but other signatories to this are the Infectious Disease Society of America, the American College of Physicians, Society for Maternal Fetal Medicine, American Public Health Association, I'm probably missing one or two others. And the suit alleges that Kennedy violated the law, that it creates a threat to the professional organizations and to patients. There is so each of the organizations is a plaintiff, along with a unnamed physician who's currently pregnant, who is standing in for the class of pregnant people who may have difficulty accessing COVID vaccines, which is one of the groups for which they're most critical. Each of the societies is going to have two declarants who are going to go before the courts and explain the harms that are done and deal with the scientific questions. I'm going to be one of those declarants for the Infectious Disease Society of America, so that will be interesting. I expect to lose strips of flesh going up against the Justice Department lawyers, but I think this is work that has to be done. And without some way to stop this inexorable destruction of our vaccine enterprise that is going on with new additions almost weekly, we're going to be in a very difficult situation. So new guidelines will help us all know how to use the vaccines. The lawsuit may lead to the restructuring and reorganization of ACIP, but will certainly aim to stop Kennedy from making unilateral decisions that normally require months of work by experts. And we'll try and come up with remediation to improve access to people. And the last thing I want to say about vaccines before we get into the questions is think about the two groups that are no longer recommended to receive COVID vaccines due to Kennedy's unilateral discussion. One is pregnant women. The CDC made a very nice presentation at ACIP about the ongoing burden of COVID in infants. They have children under 6 months have hospitalization rates that match or exceed people over 65 for COVID, because unlike the rest of us, they have no immunity. And whatever immunity they have comes from mothers whose immunity is fading. Maternal immunization is best protection for infants. Moreover, pregnant people are at very high risk of hospitalization, intensive care, and death when they get COVID. So it's a twofer of disastrous bad medicine to no longer recommend the vaccine in these populations. And I'll stop there because I'm sure we'll have lots of questions and can have a vigorous discussion here. What I wanted to get across, though, is that while it's a terrible situation, we're pushing back. We are going to try and make the best of it and see if we can't weather these 3.5 years.
Awesome. Thank you both for those great insights. I want to summarize a little bit of what I'm hearing, and then maybe you can help me know if I'm understanding this correctly. So the ACIP, as it was, is no longer there. There's turmoil at the CDC level, unilateral decisions that are not evidence-based. Health insurance plans on the commercial side, there's an organization, AHIP, that is kind of their professional group saying, hold the course, stick with evidence-based vaccines. Some commercial plans have said, we're on board with that. We're still waiting to hear from others. So on the commercial side, did I understand that correctly?
Yes, I think you do.
Okay. I just quickly on that, I was in a meeting with Health Choice and Molina. Now Molina's national, so I don't know exactly where that's going to go, but their intention, at least in this meeting, was we want to continue to support evidence-based recommendations and that kind of thing. So there's that. The other thing I want to make sure I understand is this group CIDRAP, Andy, that you talked about, is in some ways trying to make a centralized place for vaccine recommendations that potentially health plans could benchmark off of. Is that a fair summary there? Okay.
That's the idea. They're trying to coordinate the efforts of all the professional societies and bring them into one place and avoid the potential situation of having different recommendations by state or by society.
Okay. And then I want to get back to Dr. Rena Tam's question about VFC. This is where I remain the most concerned, and maybe somewhat terrified, but I want to stay calm as well, I think, as has been pointed out in the chat. So she asked, will VFC funding continue, as the first question? And my question is, just to be specific, what about a pregnant person with Medicaid who relies on VFC for vaccines? Will they not be able to get the COVID vaccine now?
So VFC vaccines for pregnant women up through age 18 are covered that way. So VFC does not provide coverage beyond age
Okay.
18. But as you said, VFC is probably the one pain point that would cause that there's the most threat for disruption of our vaccine programs, because the purse strings are held by the federal government, which also constrains some of our state health departments from being too independent in their decision making. VFC is a codified program, and its funding, it actually, there's not a cut funding level. They are required to fund whatever is ACIP recommended. But ACIP has an extraordinary amount of control over the funding that will go out then, and which vaccines will be funded. And so, yes, VFC is probably our biggest threat. There's also some threats to our EMRs and registry programs, since CDC also controls the programming language and criteria that go out to inform those as well. Those are two big areas that could be, if they were dismantled, would completely throw our vaccine programs into disarray. But on the other hand, there are some things that we can see as ways to move forward as clinicians. You who are physicians and AAP and advanced practice practitioners have some ability to deal with, as you do with every FDA approved and licensed product, you can prescribe off-label. Okay, so even if the FDA does tweak things, if this is an approved product and you have better evidence-based guidelines, you have some prerogative to continue to provide those vaccines or those products in according to good evidence, but it'll take longer to be describing and explaining that to people. That thing that also could be really, then this is why I had that slide about our pharmacists. They don't have the abilities that our physicians and APPs do, because they are required to have somebody that it refers back to, in most of their practice, refers back to ACIP. In Utah, it also refers to state and local health department rule guidelines, but those state and local health departments will find it very difficult to move away from the federal guidelines that dictate where their funding comes from as well. So the other thing to remember, as of 2024, we have a childhood and a very robust childhood and adult vaccine schedule that we can fall back on. The place that we will see the most hurt is in vaccines that have to be approved every year, not vaccines that have previously received approval and recommendations. Those we can continue to work with. It puts a halt on some of our new development, but it also, we have a good base to start with. And I think that those, we have to look towards the positives as well as what do we have to start our work. And we can continue on, but we will see difficult things with COVID. We will see possibly difficult things with influenza because those ones have to be approved on an annual basis.
Thank you, Tamara. Andy, anything you want to add there?
Yeah, no, just one of the goals of the lawsuit will be to make sure that this kangaroo court of an ACIP is not in place that might help protect VFC. And one of the damages that's being alleged in that lawsuit is the loss of access.
Okay, good to know. I reached out to in the state of Utah anyway, the VFC team, and they said they were still doing fine and you know, providing vaccines and moving forward. And so that was good news to me, at least. I know there are folks from other states on here too, and I think that might be something worth checking into, kind of the VFC team and how's it going at the state level. But
yeah, no changes yet is what you found out, and I think that's very helpful.
yeah. Okay, we have some other questions here. Let me scroll back up. There was also a second question from Dr. Tam, I think, about are Intermountain Primary Children's VFC enrolled? I believe the answer is yes. But that kind of had to be for the nirsevimab situation.
Yes.
Mm-hmm.
Yeah. Okay. And then from Angela De La O, what websites do people refer your patients to for information to debunk common concerns? I've been using the CHOP website. Are there other ones?
Boy, I didn't come prepared. I have a list of websites that I use, but I don't have them. CHOP's very good for family use. AP has consumer pages. There's another, Tamara, help me here.
Well, so the one that started off as Every Child by Two, which is now immunize.org. I'm sorry, two different things. Wrong. But yeah, the immunize.org. You can refer people to, and it's not just that's where actually I refer clinicians to. So they are the ones who are going to be our body of memory of what we have had. If things get, I said, if things got wiped off the CDC's webpage, you go to immunize.org. They're the repository for good clinical evidence base. They're the ones that give you your Ask the Expert program for vaccine nuanced recommendations and all sorts of practice tools. So they're a great group. And it's Vaccinate Your Family is the new Every Child by Two group. So if you go to the Vaccinate Your Family, they're a wonderful advocacy, but also information group.
Yeah. And another question was, how do we keep up on changes that are going on? And I put a couple in the website. AP news page will update on new changes. If you want just a news feed that has a lot of good public health information, the main CIDRAP news page is quite good and focused on useful things. And then if you are a Substack user, Jeremy Faust, who's an ED physician from Boston, has a Substack called Inside Medicine. And Jeremy seems to, he's got all sorts of sources. He breaks stories from inside the FDA and inside CDC. And I found that really helpful. And I know him, he's a really good guy.
Awesome. Great thoughts there. I'll just mention that there's a Let's Talk Shots website with Johns Hopkins that they've done that is excellent, actually, to support families. That's another good one. So I think just to get back to that question, that's one that I've seen. Now,
I mean, a great resource, Neil, might be for Utah AP to put together a sheet and a page so that, you know, people who aren't taking notes here of something can easily hand to their families or put on their screensavers or whatever.
Yeah, that's great. Great suggestion. I think we can take that back to the Utah AAP. Question here by Richard Backman. If prescribed off-label, then would you still be covered by VIP? I wonder if that's VFC. I'm not
No,
sure.
that's actually the protection program that we have, 1996.
Okay.
Yeah, the Vaccine Injury
Yes,
Act.
I got you.
And so, yeah, really great question, Richard, because I'd have to go back and look at the actual criteria on it. But as Andy was showing and CIDRAP's talking about, that program is under threat as well of being revised by Secretary Kennedy. So I'm not sure what we will see change on that program or what rules might be put in place about it.
Yeah, and that program is no fault. And tends to be pretty inclusive. So if you gave a vaccine that has previously been recommended, but the recommendations have changed recently, I think it's likely that the case would be considered until the whole VIP program is dismantled or whatever happens to it.
Okay. Thanks for that great question and great answers there too. Another question from Sarah Woolsey. Any comment on reduction of funding for mRNA vaccine for future formulas? I mean, it was such a promising area, right?
I mean, I could spend the next hour talking about that, but so there is a very effective mRNA flu vaccine that was just published, I think, in the New England Journal of Medicine that was going to come out, and now its future is uncertain. mRNA vaccine for RSV is effective and an alternative, but what is really most important about mRNA vaccines is they are our only way of responding quickly. So if we need an H5N1 vaccine that we could make 600 million doses of, it's the only technology that can do that. And there are improvements, that were underway to improve the potential durability of mRNA vaccines. There are self-amplifying mRNA vaccines that would be even faster to produce. And then there are these enormously promising areas like mRNA vaccines for cancer. So the cutting of this is disastrous for vaccine research in cancer, for pandemic preparedness, and then for offering us additional vaccines against common illnesses. There's a COVID and influenza combination vaccine. Again, results were published not too long ago that was as effective or more effective in terms of immunogenicity as the individual components at the cost of a little bit increased sore arm and febrile reaction, but you get a one shot and cover both annually. Again, whether FDA will license it despite the trials haven't been completed according to FDA specifications and been quite successful is unclear.
Okay. And then a specific question, what about the status, just a quick summary, status of the 2025-26 flu shot? It was approved, right? Just not the multi-dose vials. Is that the
Yeah,
short version?
there really is no disruption to influenza vaccine for this coming season. That's settled. It's COVID vaccine that we are waiting to see what occurs.
So normally the new formulation would be getting licensed about now after an open meeting of VRBPAC, and then the recommendations would come out. So to have the updated formula, we have no idea what's happening with the speed with which anything's moving there. Last year's vaccine is still effective against the current variants, although possibly a little bit less so. So it will be available to the groups that are recommended under the new regime. But suddenly I think most of the US will have a little bit of hypertension or will have been caught wheezing once or twice so that they have eligibility for vaccine.
And if you look at the New England Journal of Medicine article that that Dr. Bakary and Dr. Prasad published, and that table that shows which are the high risk conditions, physical inactivity is on that list. Okay, so I think most people can claim a high risk condition if you talk about that, as well as the pregnancy and recent pregnancy are on that list as well.
Yeah.
Okay, and that's specific for COVID vaccine.
That's for COVID vaccine. Yeah, okay. Influenza. We're still both Annie and I talking about COVID, but influenza is tucked in, and we're good to go on that.
Yeah, but I think you can find a high risk condition without being fraudulent or pushing the boundaries too much for most people.
Sure. And this, I think, goes with the next question in the chat from Miguel. The CDC vaccine recommendation removal was for healthy children and healthy pregnant women. So it seems like VFC would still cover for less than 19 if you have a risk factor. I think that goes along with what you're talking about.
Yeah.
Is that true?
Correct.
Yeah. All right, great. And let me scroll down here and make sure I'm catching these, except we got that answered. Okay, the question from Mary Burton. So should we only do COVID vaccine on kids if there is a high-risk condition? What's the short version? What do we do in community practices with COVID vaccine now?
Well, so part of it's going to depend on parents and joint decision making, but
sure.
here's what I think the data show. Very young children and those with no pre-existing immunity are still at high risk of COVID complications. And so if you've never had a primary series, I think there's a strong case for vaccinating all children. If you've had a primary series and have been infected several times, you have a higher degree of protection. Your chances of having severe illness are lower. You're still at risk for getting long COVID. And the current variant seems to be fairly nasty. It's causing, you've read about razor blade throat and that sort of thing. But there's a less compelling argument for, say, the 9-year-old who's had a full primary series, a booster, and gotten COVID once or twice. So I would emphasize, in talking to family members, I would emphasize infants, young children, and those with risk conditions, and offer it to everyone, but understanding that I think, there the benefits are more modest.
Okay.
And
Awesome.
once again,
Thank
we
you.
will not know what ACIP's position is until they've met on this. So we may have to be pivoting pretty quickly depending on what happens during that meeting.
Yeah. The real ACIP was going to address the recommendations for children with a careful look at the evidence and who was still getting sick and that sort of thing. But of course, that isn't happening now.
Can we look to CIDRAP for that though? I mean, I'm afraid I'm not going to be looking to ACIP myself.
Yeah.
I'm not sure I'm that interested in what that group has to say, but CIDRAP seems like a group
Yeah.
I could look to. Is that fair?
And I think you will see, under the auspices of AAP, a more careful discussion of what to do for older children and healthy children. Because I think that is an area where a really careful look at the evidence and at the harms. So, the risk of myocarditis has gone down in subsequent years. So the risks are lower, but likewise, the risk of severe disease is lower for many healthy children who've got pre-existing immunity. So that's the sort of thing that would require some serious work to come up with recommendations, and that'll hopefully happen through other organizations now.
Let's end with just a question for both of you on any counsel for us as community pediatricians interfacing with our patients, with health plans, just in this whole situation. How do we approach this, even from a mindset perspective? And let each of you respond, and then we'll wrap up.
I think it's really important to advocate for vaccines and to explain to people that many things they're hearing, are from a perspective of people with no science background and a very strong anti-vaccine perspective. And, just keep explaining to your neighbors, your patients, particularly if your neighbor happens to be an office holder, that's a really good group to speak with and to educate as best you can. But I think we just have to advocate, without being too confrontational, but also without giving in to misinformation.
And Neil, you talked about my presentation, trying to be calm about this. I think that's something, as we talk to patients, that we need to be modeling is they come to us, and the people they have the most confidence in about vaccines invariably is their primary care practitioner, the person they have the relationship with. That relationship needs to be one where you are exhibiting calm confidence about the recommendations you're making, and about about your confidence in vaccines and the science behind them. So we all need to keep looking forward as each new barrier gets put in place, how we will come up with solutions. And we will work around this, and all together we are going to come up with solutions. So rather than, the horribilizing, these are disruptors, and we have lots of disruptors going on in our practices right now, and for positive reasons as well as what's happening nationally. We have to be able to exhibit our calm through this storm, and be ones that people can look to for a reasoned approach, and do it with caring and with the patient focused first, always on our decisions.
Well said. And remember, we all respond to stories more than data. We respond to data more than most people, but, I've vaccinated my children. I've seen children die of Haemophilus influenza. I had a patient who ended up on ECMO with influenza last year. I've taken care of kids with measles. It's horrible. I never want your kids to have to go through that. These are the kinds of messages that often work best rather than saying there's 17 studies debunking any link between vaccines and autism. It's not 17, it's 29, I believe.
Okay, thank you very much for your insights, both of you, and your expertise, and for the community for the great questions. Let's keep a steady hand at the tiller and keep going forward. We're going to make it through this. Thank you, everyone, and have a great day.
Thanks, everyone.
Thanks, Andy and Tamara. Really, really appreciate you both.
Neil.
Oh,
Yeah.